Hello, Purun ma'am.
Hi, good evening all.
Good evening. Good evening. Yeah.
Hi, good evening.
Hi, Tina.
Good evening.
How long is this meeting? Is it 30 minutes or 1 hour?
I think it's not yet decided.
Nirav, are we live?
So just a moment.
It's a 30-minute session or is it for 1 hour?
It
1
depends
hour.
on the live
One.
answer, how much time. Yeah.
I guess mostly 1 hour. It will take
Yeah.
1 hour.
Good evening, Uday sir. Good
So
evening,
just a
Dr.
minute.
Gupta.
I'll just confirming you.
How are you?
Good, good. Dr. Gupta's in the US, right?
Yes.
So good morning, Sunil. Muted है तू.
Nirav?
Are we good to go?
Okay, great. Great. So, good evening, everyone. I'm Dr. Rutul Goklani, consultant diabetologist from Ahmedabad, and today's special show of IDF Southeast Asia is merged with D-Genius. D-Genius is a young diabetologist group from Diabetes India. So we are closely working with IDF Southeast Asia as well. And this time it's a very special program and a very special episode of management of hyperglycemia in pregnancy. And that is about Southeast Asia perspective. And for today's program, we have our moderator, Dr. Priyanka Kukrele. She is from Jabalpur, India. And our panelists, esteemed panelists, are from different regions of India, as well as we have one Southeast Asia representative is from Nepal, Dr. Deena Shrestha, who is an endocrinologist, very well-known endocrinologist from Nepal. We have Dr. Sunil Gupta, sir, who is from Nagpur, very well-known diabetologist of India. Dr. Purvi Chawla from Mumbai. She is also very well-known face, and we all know her. She's very active on social media, so we don't need more introduction. And we have Dr. Uday Thanawala, who is only OBGYN in our panelists. So Dr. Uday Thanawala is from Navi Mumbai, and he is a gynecologist. So we request Dr. Priyanka Kukrele to start our session.
Good evening and thank you, Dr. Ruddal. And I welcome all the panelists for today's session on one of the very important topics because this deals with not the one life, but it deals with two lives, that is diabetes in pregnancy. So, moving the ball. So, my first question will be to the panelists will be, now, what is the prevalence of diabetes in pregnancy in the Southeast Asia region, and how it is putting at risk to our mother and to the developing fetus? So I request our panelists to kindly answer the questions.
I guess we may start with Sunil Gupta, sir, and then Dr. Deena Shrestha.
Yeah, definitely.
Thank you very much, Priyanka. And I feel it is many of the people may not be aware in the academic gatherings that gestational diabetes. Now we should know that hyperglycemia in pregnancy is an umbrella term. So you have the hyperglycemia pregnancy, which is subdivided into two. One is DIP, that is diabetes in pregnancy, where you are pre-existing type 1 or type 2 become pregnant, and then you have to take care of their hyperglycemia. There could be other group of people where they become pregnant, but they are not already diagnosed, but they are clinically like a pre-existing diabetes, because many of these women get pregnant with between 25 and 30s, and if they have not tested their blood glucose, they might be having pre-existing diabetes, and HbA1c might remain high, and the fasting postprandial, which matches the previous the diagnostic criteria of a non-pregnant state. So they come into the category of DIP, that is diabetes in pregnancy. But when it comes to gestational diabetes, then it is a state which actually appears during pregnancy, commonly after 24 weeks. But now we have seen that almost 20 to 30% of these patients, they appear even in the before 24 weeks. So maybe from 12 weeks to even 20 weeks, a lot of patients are being seen. So these cases who are diagnosed for the first time during pregnancy, not matching the pre-existing diabetes cutoff of WHO, and they are diagnosed as gestational diabetes. It appears in pregnancy, and commonly it disappears after delivery, almost 85% of the cases. When you talk about total HIP, total, that means pre-existing as well as GDM, the prevalence comes to almost nearing Southeast Asia, almost fourth women. So almost 25% in Southeast Asia. When it comes to India, it comes to around 20%. So every fourth or fifth woman in Southeast Asia, one of them, out of them, 85% will be pure GDM and 15% will be pre-existing, that is DIP category. So that is why we say that every woman should be screened for hyperglycemia and pregnancy. So prevalence is high, but unfortunately, the awareness amongst the academicians, the institutes, the practitioners, amongst OBGY, still need a lot of aggression. I feel every panelist here will agree on the point that we need to have a lot of such programs to make OBGY especially sensitized that it should not be a random blood glucose, it should not be just a fasting blood glucose. Some of them, they still do urine sugar, may not, you may miss out many cases. And that is why it is important to know that every fifth of woman in India or every fourth woman in Southeast Asia might be having hyperglycemia and pregnancy. And if you don't, and in your own introduction, you have just said that we are taking care of two people, the women and the baby. And that's why we should have good quality awareness across. So prevalence is high, and awareness is must, and that's the only tool we can reach to people through such programs. I congratulate Dr. Rutul and the team of DGenius that they have got the collaboration with IDF, and I really endorse that they have taken this program on that banner and trying to now bring awareness going away from India, involving Nepal and Southeast Asia as a whole. I really compliment the whole team. Thank you very much.
Thank you. So we have Dr. Bansi Sabu, sir. Before we move this question ahead, we want to have some words from him, and then he may start again his OPD.
We welcome Dr. Bansi Bhai.
Thank you, Rutul.
It's his
First
brainchild.
of all, thanks the complete team and all the speakers and faculty member from IDF Southeast Asia. Being a Southeast Asia chair elect, I'm welcoming you all, and I'm also welcoming all the delegates and all the participants who are joining. When Rutul asked me that we are going to do a program on a hyperglycemia pregnancy, if you see the IDF data, in compared to other regions, in Southeast Asia, we have hyperglycemia and pregnancy is very, very high compared to the Western Pacific or compared to the North America or Europe. So, I mean, if all the regions, we have very high, in this particular regions, we have very high. Somehow the awareness or the treatment, even we are doing so many programs and so many activities, and there are dedicated program for diabetes in women. There is a dedicated group under Diabetes India. Then we have DIPSI, we have pregnancy study group, and then South Asian Federation, that CEFIS is also doing a dedicated program on diabetes in women. Still, I think the awareness and treatment is suboptimal in these countries. So the online program will definitely increase more awareness. What more needed is we have with us Dr. Uday Thanawala. So, I mean, if we can involve the more gynecologists, if we can involve more obstetricians, I think it will definitely improve the care for diabetes in women. That is going to change the way we are treating diabetes and pregnancy. Because in UK, where one or two hospitals where I visited, the dedicated center, even for diabetes in women, it is primarily taken care by the gynecologist and the endocrinologist and diabetes. They work together, but that's not situation in our country. I mean, we work independently, and I don't know, Dina, how Nepal is doing and how Bangladesh, where it is, uh, everything is under burden. There is a dedicated diabetes hospital, but still, we have to learn from the other countries also how they are taking care. And in India, it's being large country, and Southeast Asia, I mean, it is like a India subcontinent. It's like Nepal and Bangladesh, Sri Lanka, they all are part of more or less with this Indian subcontinent. So I believe they may have same, but we have to learn from them also if they are doing something better or something different. And we have with us like eminent diabetologist Dr. Sunil Gupta, who is not only expert in diabetes, but is special interest in diabetes in pregnancy. And this, and along with us, we have Dr. Chawla. And Rutul also have a lot of interest in diabetes in pregnancy, who is running a pregnancy study group. So I congratulate all of you and thank you for joining for this meeting. And thanks to all the speakers who could spare their very valuable time. And we will be sending this letter also to the IDF and Southeast Asia. We a newsletter also come every 2 months. So where also you would like to put your photographs to this. Thank you, thank you very much. But if anything is special come, please let me would like to know. I'm sorry, I still have few patients, but we will continue and in between I will again join. I'm just
Thank
keeping
you,
it
sir.
silent, keeping my video off. Thank you.
Thank you very much, sir. Yeah. So we would like to know something more about prevalence and hyperglycemia in pregnancy from Dr. Dina, if you can throw some light.
Thank you so much. I think what is most important is what Doctor really elaborated is like we really need to know the difference between diabetes in pregnancy and gestational diabetes. I think that is one of the most important confusion that is happening. Even diabetes in pregnancy is being managed like gestational diabetes, which is obviously they are like apart because when the sugars are so high, you want the management to be different. So awareness is definitely important. When it comes to prevalence, we know that gestational diabetes or hyperglycemia in pregnancy represents the society's burden of diabetes and obesity. So when we are having more diabetics and we are having more obese women, and also the fact that Nepal is there, of course, and I'm sure India is the same, that we are having women who are getting pregnant at a much, much later age. So it's not, and that is also another risk factor for diabetes in pregnancy or hyperglycemia in pregnancy, let's say. So the burden of diabetes is increasing, the prevalence is there, awareness is lacking, and it represents what is actually there in society. That is the bigger picture, that there is more diabetes and there is more obesity in the society. I think I will just add that comment and let others.
I really appreciate Dina here. That the age of marriage and childbearing is going up. So earlier when we were born, most of our mothers were less than 25. But now most of the new mothers, they are coming, the average age in JDM is coming almost 28 to 30 and even crossing 30. So age of pregnancy is going up and age of diabetes, especially type 2 diabetes, coming down. So age of diabetes, which used to be in early days of 50s and 60s and 40s, now it's coming to 30s. And there's going to a big mismatch, and we are going to have more and more cases of DIP, that is diabetes in pregnancy, in this hyper HIP. And that's the biggest challenge because these patients, they remain undiagnosed, untreated for in the first trimester, which becomes a very big risk factor for these offspring of diabetic mother who had high HbA1c in the first trimester, in first 8 to 10 weeks, and getting exposed to this hyperglycemia. And recent figure of Lancet says that the 141 million pre-diabetics with us. If you remember, Dina will agree with me, and Rutul also will agree with me, that earlier we used to define what she rightly said, Dina, that prevalence of diabetes matches with the GDM prevalence. We used to define prevalence of IGT in the society matches with the prevalence of GDM in that particular society. That used to be the definition earlier before the IDF figure has come to 20%, which is much higher. And that is why there's going to a mismatch of this kind. So we are going to more and more cases. We all as clinicians, will be facing more and more cases of this pre-existing type 2 diabetes more often. So more of a dip will increase, and GDM, of course, is already high. So we have to be more careful, more aggressive, more intense, and more aware of this kind of picture.
Definitely, sir. As you have mentioned that prevalence is increasing, I would like to add on one more thing. As I am attached to a medical college, sir, we have rural population over there. Earlier, the prevalence was not that much, and now in last 1 decade, we have seen that even in rural populations, also because of late marriages or whatever factors are combining, their prevalence has also gone up. Like without obesity, also their prevalence are increasing. Like I am also doing studies in that, and I am getting like 15 to 18% prevalence in that rural population now.
Yes, so it is urbanized rural hospital, rural places. Not, it has not remained as rural now. It's everything
Yeah,
is being
I
urbanized.
think
If you
I
have one
think
fridge
that
in your house, and if you have gas chulha in your house, it's an urbanized home. So
yeah,
this is there everywhere. So very
no,
true.
but then the rural incidence was always known to be high, because this is what Dr. Sheshaya study also, which he done in rural Chennai, it had come to around 13 to 17%. I mean 17%, when we were shocked that how come this is the incidence of GDM. That's when we started looking at GDM so seriously. And the rural, it's not because of the late marriages or something. The inherent population is, we Indians have bad genes. We Indians are more prone to diabetes. And that is why the incidence of GDM is very high. In my practice also, it has gone up. When we started really testing it in the DIPSI test in all the antenatal women, the incidence is around 13% in my practice. No, 11 to 12%, 13%. People have reported incidence of 17 to 20% in their practice. So it is basically all uniformly, we have found that the incidence of GDM in the South Asian Eastern countries is high. And that is the reason we are banking, and we are insisting on universal screening, and we are
Screening.
not following the guidelines which were given earlier by the American Association and all, that do only selective screening. We South Asian people, we have to do universal screening to pick up these cases and manage them properly, so we don't pass on this high load of diabetes to the next generation, so we can bring down the incidence of diabetes overall.
So I just want to add that, I think great points by all the experts so far. And I think it's important that we make people aware that this is a vicious cycle that we are getting into. So, one generation with gestational diabetes or hyperglycemia and pregnancy means we are feeding not only the next generation, but the same woman continues to have increased risk of not only obesity in but the type 2 diabetes itself and cardiovascular morbidity and mortality. So, it's even that itself is really under recognized, even though, we clinicians have started to acknowledge that more and more. I think the general understanding in the society is very low as far as the long term complications of the same go, and the fact that if you have gestational diabetes in one pregnancy, your risk for the same is very very high, or almost 100% in the subsequent pregnancy as well. So yes, our society is going through a sea change in terms of age of marriage, the lifestyle, and even bearing children, and the number of even artificial procedures used to for reproduction. But at the same time, I think our understanding of what helps is also increasing. So we need to make people just aware of this entire vicious cycle and how we can break it. So, yes, great comments. Probably we can move forward with the conversation.
Can I add one more thing to Dr. Uday's? So another reason why in rural areas that you can have gestational, like higher gestation times, this is just theory, is that children born uh, with malnourishment. If the mothers were malnourished during their pregnancy, the children who are born to them are actually at a risk of diabetes. So even rural people who
Correct.
may have low pancreatic beta cell mass, and that is the reason that even if they're not urbanized, But with the Danish famine, that is what was established. So that might also be the reason why in your area, I don't know what was the nourishment in the rural areas, but children born to malnourished mothers could be the reason why the next generation is having GTM. I think like that's something
Yeah,
also.
that's very true because we know that those children are more prone to diabetes and cardiovascular diseases in later life. A very important point.
So it is if the birth weight of a child is less than 2.5 kg, or if it is more than 3.5 kg. So microsomia or maybe the low birth weight as well as the higher birth weight, both of them are the risk factor of developing diabetes and non-communicable diseases or cardiovascular disease in their adult life. So both of the things are important. That's why we try to keep the goal of around mean 105 milligram, the fasting 90, postnat to 120. We neither go below 87. Below 87, this has been documented very clearly. Will mean blood glucose of below 87 might be a risk factor for IUGR and low birth weight. And more than mean blood glucose of more than 105 becomes a risk factor for macrosomia. So we have to be careful, neither be too tight nor be too relaxed. Very true.
Thank you, all the
So I
panelists. As
guess
we came to know, awareness is one of the most important key for reducing the prevalence of this problem. So, Dr. Rutul, you have any thought on this?
I guess no, all the panelists have given wonderful answers. I guess we can move forward to the next question. And I have a question that what should be the screening technique, when to screen and how to screen, and whom to screen is very important question. And I would request our panelist, Dr. Deena, to start as in India, we discuss it so often about screening. Anytime when we have any conference, even it is not a diabetes and pregnancy conference, we have the more focus is always on screening. When to screen, whom to screen, and how to screen. So we would like to hear from you, and then we'll discuss.
I am thinking what is the appropriate answer for that. But the only thing that's coming to my mind is like, what car do you want to drive? You know, so it's literally like that. So how much money do you have? How much access to healthcare you have? You know, all that in mind. I think that is important because sometimes when I tell
But this
people,
is this is Southeast Asia perspective. The specific program is on
yes,
Southeast Asia perspective.
so
So stick
in
to that.
Southeast Asia we have people who are going in there because I'm privileged to say that I work in a very corporate hospital in an international hospital. And people, obviously, we know that Asians are at risk of having diabetes. So I would want to screen them before they get pregnant. So, and then I would want to do them each time I meet them because cost is not an issue, access to healthcare is not an issue. Like, I would like, so as much as you can, whenever you can. I would say if you're an Asian trying to get married, you have a family history of diabetes, you have a history of PCOS, obesity, bad lifestyle seems to be a part and parcel of being Southeast Asian, even so I would say that as frequently as you can, but if you can't, don't miss obviously the 24 weeks period. But I would want that as the Dipsy, I think if the Dipsy does
In each trimester, so you
each
mean
trimester. Yeah. So I would start before the trimester. So when you're planning for pregnancy, so that we don't miss out, like Dr. Sumit said, the most important, like diabetes in pregnancy, we don't want to miss that, right? Then I would do it each trimester, and I would each visit, even a postprandial of 1 hour, I would not miss. And people usually say that an HbA1c is not a good test for pregnancy because of the low hemoglobin and it's a turnaround of 3 months. But what I would say is that I would also want to do an HbA1c, a glycosylated hemoglobin, because what if it's an 8? I mean, so that's something I think that if any patient can afford to do it, they should have not lose the right. That is my.
Yeah,
Um,
Rutul,
I think
yes, sir.
so that the audience gets the right message from today's wonderful program. I'd just like to add that I think Dr. Uday sir and Dr. Sunil Gupta sir have set the stage for that universal screening, which is very, very well appreciated. I think that's the clincher, that we screen everybody, because inherently, as being Asian Indians, our risk for gestational diabetes is so high. Plus, the preconception counseling is not where we would like it to be, which means that a lot of diabetes itself is detected in during pregnancy. So that first contact and screening at that time is extremely important. And I think again and again we have several studies to show that the DIPSI criteria is good, and the DIPSI procedure is very simple, pragmatic, and scientific as well. And we are not really losing out on too many, even though some may argue that, it's the fasting which is most important for the Asian population. Uh, so I think I'm just initiating that discussion, more input from Dr. Gupta sir and Dr. Uday sir as well.
I think what I wanted to say is that no doubt I like universal screening, it is there. That is there. That is like we're
Correct.
not doubting that. But what we are saying is that also we don't want to do universal screening at 24 weeks. We want to do it
Right.
if possible before the pregnancy when you're planning. As soon
Absolutely. That would be the perfect thing to do.
So, Dina,
I,
what test do
I
you
feel
do over there in Nepal? Which is the screening test which you resort to?
we're doing 75 grams OGTT. Like if we
So you are
really
doing those four readings.
no, we are only doing fasting 1 hour and 2 hours.
So yeah.
And
So you are
what
doing three
criteria
readings
do you
anyway.
So
follow?
That's why you are, yeah.
IND-PSG
So that's why you are,
criteria and
yeah.
ADA,
Yes.
that is what you
Yeah.
follow. Right.
Yeah, so that's why you are saying that it is expensive. And so in India, we have switched over for the DIPSI test, which is universally done all over in India, and you can do it in all practices, whether it's in my private
50
practice,
grams
which everybody can
OGTT.
afford it, or the general practice, because it's only 1 2 hour reading, which we do after giving 75 grams of glucose. We all agree over here that a pregnant woman or anybody has to be low to challenge the body to produce the result, whether she's got glucose intolerance or no. So the DIPSI test is very pragmatic because whether you do it in a fasting state or you do it irrespective of fasting, because in India, women do not come in a fasting state to the antenatal clinics, and it's very difficult for them to travel very far and wide and come in the fasting state. So we have adopted the DIPSI test over here, where irrespective of the fasting state, we give them 75 grams of glucose when they come. And after 2 hours, we do a reading, and we need not even do a phlebotomy, or we don't have where the facility is not available. We simply do a point of care by the glucometer. And if that reading is 140, we label it as a DGDM. And this is there in the Indian guidelines that we do it in the first visit. We do it at 26 weeks to 28 weeks. And if required, we do it even in the third trimester. It is important to sometimes screen these women. So that's what we are doing in India, and I think it's working very well for us. So Nepal also, we had done a program in Nepal, I think 2006, 17 or 18, propagating this particular test, the DIPSI test. And I think it is something which is very, very doable in all Southeast Asian countries, because it's just a single test. Cost doesn't become a factor, and the accessibility and the doable test, it's a very, very doable test in any obstetrician's practice.
I think that that sound does sound good, but how do you follow up with that? The problem is like if they, that time it's done. Say this patient has 147 sugars. So then, would you do a glycosylated hemoglobin? Would you again have to do an OGTT? Would you
No. This is a single test which is diagnostic, totally a diagnostic test. We don't repeat any other test. We do a single reading two
no, but
hours after
how would
giving
you
her
manage?
glucose load.
So
We
after
manage her
that,
as a GDM.
I guess Gupta sir can answer it better. So what to do further?
147.
Yeah. So Dina, we have when we ask this question about screening, important, you have very rightly said that we should give all the opportunities of all young women who are planning for pregnancy. I'll say from the puberty itself, and not even before getting married. Even before getting married, from puberty onwards, they should be focusing on all these things what we are speaking. But when it comes to practicability of it, let me ask every panelist here, we have most of these women who have been exposed to pregnancy. How many of you before pregnancy have got your blood sugar checked?
Nobody.
Nobody. So we know
Really?
the real fact that most of us, even as a medical professional, very elite group of people, well-educated family, have never tested a blood glucose before 30 years of age, and you suddenly get married, and suddenly you get conceived, and then you have all those celebration, go to a doctor. That too, you go not in the first trimester. Usually, you go after 10, 8 or 6 or 8 weeks. By the time everything is already lost. So theoretically, yet it seems, and then unless and until the government comes out with a policy that at the time of marriage you should have this certificate also, like you have a Aadhaar card with you for the marriage and proof of citizenship of a country. You should also have a blood group as well as blood sugar before getting married, and hemoglobin, something or sickle cell disease. A lot of things are there, so it becomes very theoretical when we say that before pregnancy. But yes, we should certainly incorporate these guidelines that education should start before conception. Very important. The way the diabetes is increasing, and that should come now into the clinical practice and clinical recommendations. I fully agree with you. When it comes to general population, we are talking about rural population where even people don't have a established good lab. At least you have a glucometer. 70% of the population in India is rural population, and 70% of pregnancies also will be coming from the rural population, where you don't have good quality labs, where you don't have good quality system available for assessment of the blood glucose. And when you talk about fasting blood glucose, the wonderful multiple studies across the globe in the social in the academic platform available. When you call person in fasting, the turn up rate is hardly 20%. So when you call 100 women, only 20% come back for the fasting. That's a situation in developing world like India and maybe even Nepal. And that is why it makes doable. If someone wants to, if I want to do in my own patient, and if they are able to come to fasting state, we are more than happy to do it. Nothing wrong in doing fasting blood glucose and assessing it. But then in a population based things which is applicable for everyone, every woman, when we say every pregnant woman should be screened, then it comes to a mass screening program where dipsy test, or the which is government of India recommendation test of 75 gram glucose. If you come fasting, do fasting as well as do postprandial blood glucose, blood glucose more than 140. Just subject them, label them as GDM. 70 to 80% will do very well only on diet therapy. And there's a wonderful study. I'll quote two studies for our all academicians. One is a CGM data. If you go through the CGM data in non-diabetic pregnant women of the same trimester, if you just see that we have done that data, and many of the data are already available in non-diabetic pregnant women of the same trimester, the mean blood glucose never exceeds 105, around maybe around 97, I feel. The fasting goes, mean fasting is around 67, 68, almost 70, 72. So when we give glucose in a non-fasting, even if you're taking glucose, the CGM is not going up. That means whether you give non-fasting or fasting, if you have beta cell, which is compromised, it will shoot up. Concept is very, very simple. You are giving, it is a treadmill test for the beta cells. So when you give glucose, the blood glucose will go up, and those who have beta cells are already compromised. And if your beta cells are healthy, that will not. And that's why this controversy of fasting versus post glucose should now go away. And now there is wonderful data coming from HAPO study, follow up of these children who have been those women who have delivered in these HAPO study trial. The outcome data of these fetuses is more correlated to the 2 hour postprandial than the fasting in GDM cohort. That again shows that the postprandial is more important than fasting, especially in more country like India where postprandial hyperglycemia is more prevalent. And that is why if we do fasting, we don't mind do it. If you are doing IADPSG, we don't mind do it. When it comes to mass communication to the PSC centers and IABIs, not the this your women, the workers, women worker, what do you call it as? Uh,
Asha,
Asha
Asha,
workers.
Asha,
Asha,
Angan
yeah,
workers and Asha workers.
Asha workers.
Anganwadi workers, in those women, they are supposed to just do the things in a very simplistic way, where you do have a glucometer with you. And if the glucometer is well maintained, everything, the reports are more or less acceptable, and you can get it done. Where you have good venous plaza things available, like in a specialist clinic, we can certainly do even that. HbA1c, when we say, it has no value when it comes to diagnostic criteria. We are talking of diagnosis. When it comes to someone is already diagnosed, that time you can certainly, not necessarily HbA1c should be done in everyone. It is not at all cost effective. No recommendation globally from any guideline for HbA1c as a part of a diagnostic criteria. So certainly once you diagnose someone as GDM, you can say at least have one test of HbA1c to presume to say whether it is a pre-existing whether it's a DIP category or a GDM category. That's the only possibly value at this moment of time. And once it is a DIP category, you should certainly do it every month as a part of management protocol and not the diagnosis protocol when it comes to HbA1c. This is my take for everyone. The message for everyone who's attending this seminar by DGNS of IDF Southeast Asia is universal screening, universal screening, universal screening. Everyone should get a screen. Whichever test you can best do in your center, whichever test you believe is best done in your area, that should be done. Rather than discussing of which should be done and of course when it should be done. First trimester, second trimester, third trimester. If not possible, at least first trimester, and then again after 24 weeks, to 24 to 28 weeks in the first trimester. If patient is coming late, at least first give an opportunity and then the third trimester. So like this clear message is important. Hopefully I've tried to give very justified answer and all the faculties agree on this.
Yes,
Absolutely, sir. Very well said. I just want to refine that point on HbA1c, that even though it does not have a diagnostic value for GDM, and we don't recommend that, I think somebody who has diabetes and is getting pregnant, it's of great value to plan the preconception period also, and then go ahead with the conception. So that's where HbA1c, or the role of HbA1c, more of a prognostic value than diagnosis. But and then the criteria again is that it should be maintained at a level of 6 or less than 6% for us to give that green signal for conceiving further.
Yeah,
So
purely that
that's
is for pre-gestational type 1, no, not
exactly
type 2.
type 2
We
and
are
type
actually
1.
talking about the
No,
75
no,
grams
agreed.
GCT, because that has
Yeah,
no value. That has no value in pre-existing diabetes. There's no OGTT required, because I've seen me few people even doing OGT to known diabetics during pregnancy. That's wrong. So they are
yeah.
already known diabetic. There's no reason. HbA1c certainly will have a very strong value, because the
In
neonatal
those
outcome
cases,
in
exactly.
those cases of DIP, diabetes in pregnancy, where the HbA1c is directly correlated to the preconception at the time of periconceptual HbA1c is correlated to the neonatal outcome.
It's
Periconceptual
correlated to,
HbA1C, yeah,
yeah, the
That's
incidence of
exactly what
having
I'm
the
saying.
incidence of having congenital abnormalities in the fetus, because the first trimester is the time, even before she realizes that she's pregnant, the organs are getting developed. And if that time, if there is a high glucose load going to the fetus, there is a high chance of congenital anomalies like the spinal anomalies, the cardiac anomalies. So all these anomalies can take place. So the higher the HbA1c is at conception, the higher the chances of anomaly is there. So 25% if it is around HbA1c is 10. So that's why when Purvi said it is important to keep the HbA1c less than 6 or 6.5. That is what the nice guidelines say. Very important point, but when we are talking of preconceptional counseling in HbA1c, what Dina had brought about, don't miss the link between your PCO girls, and they are more prone to become diabetics even when they are pregnant. So keep a watch on your PCO girls, and in the general population, do the HbA1cs as a preconceptional thing definitely for them. And as far as the DIPSI test goes, one more thing, Dina, what has helped us in taking up the DIPSI test in India is that when COVID struck, all the guidelines went haywire. Everybody who was doing those, the women going to the lab, sitting for 3 hours, giving their blood, everything went haywire everywhere, whether it is Canada guidelines or Canadian guidelines or Australian guidelines. And they were wondering what to do, whether to do fasting or HbA1c. For us, it was business as usual. One reading, 2 hours, post glucose. Simple. And they used to even tell us on the phone or on the email that, okay, I have taken the glucose. After 2 hours, I've done my this thing by the glucometer, and my value is so and so. So it was very easy for us to go through the COVID crisis also.
So I guess we are done with this question, and I'll hand over the session to Dr. Priyanka again. So
Yes.
I guess we can move forward.
Move on. So, as we have covered the screening part of our talk, so my next question was related to this DIPSI guideline only, but we have most of the thing has been covered, Dr. Sunil and Dr. Uday themselves being a part of DIPSI guideline, they have already explained how important it is, so that most of the other developing countries of Southeast Asia should also think about including this in their guidelines. So moving on with the next question, which is now the
I
management.
guess may I have a comment? So I
Yeah.
guess with IDF support, we can have data of SPED guideline, INEPSD guidelines and DIPSI guidelines comparison for screening in different regions and different countries of Southeast Asia, and that data can actually help moving forward, and whether DIPSI can be helpful in our region for all the countries or not, so that we can propose this project in IDF.
I think that's a great point, Rutul. And I'm sure with Banji sir's guidance, we can definitely, and such strong collaborators on the panel today, I'm sure we can take this forward. We'll be very happy to be part of it as well.
Dr.
So
Priyanka, please.
yeah, yeah. So moving on with now the proper management in diabetes in pregnancy. Now, the first of all, we all agree that we have to start with MNT, that is medical nutrition therapy, in our diabetic hyperglycemic patient in pregnancy. So, what is your take in like MNT, when it has to be started, and for how many weeks we have to wait before starting with our metformin or be it insulin? So, what is your take on this point, Dr. Purvi? We like to share your opinion on this.
Sure. So I think literature also tells us that 80 to 90% of women with pure gestational diabetes are very well managed with a good, well planned medical nutrition therapy. And I completely endorse that and I agree with that. In my own practice, I have seen that, of course, we have, registered or experienced as well as well trained nutritionists. So it's important that you don't just pull off a diet off the internet, but you consult somebody with that knowledge and experience of giving you a well tailored, customized diet during pregnancy. And we have very well seen that most of the times that postprandial rise in blood sugars is very, when it's pure gestational diabetes, it's very well controlled with just observing and monitoring the sugars well. So medical nutrition therapy is the first for and foremost, intervention that, or so that we may like to call it, for gestational diabetes. And a well-planned diet with the right amount of protein, good fiber content, reduction in, even simple sugars and giving more complex carbohydrates, even use of millets appropriately, and a reduction in the fats, everything contributes to a good diet. And then that, and of course portion control also, although we don't want anybody to starve or try to lose weight during pregnancy. So that's why you need a well qualified nutritionist to give that plan. And when that is implemented, you can allow the patient a week or 2 weeks at the most, and with very good monitoring of blood sugars in tandem, so that we can decide whether you want to intervene with the drugs, whether it's metformin or insulin later, or it's good that the patient can continue with medical nutrition therapy and keep the sugars under control. I
Yes.
think I will
Yeah,
invite
I
comments
guess
from.
this question is not to be elaborated more, as we are running short of time and we should move forward to more important questions. I guess we should leave it to our qualified nutritionists who are really helping us very well.
Yes,
And
all
we
the
have
key points
already
have
been
been.
agreed to that point that 70 to 80% of our patients can be managed with medical nutrition therapy. So I would like to ask about now the most important questions: metformin, yes or no? And if yes, then when? And if you're starting it, and what dose? And completely no, then what insulin should be started? So it's a big question. Yeah, any of you two can take this question.
See, as metformin is one of the drug which has been most of the OBGYN they love metformin, and I'm sure that even Dr. Uday Thanawar loves that drug too much. So now, after the European Association agreed that metformin can be used from preconception in type 2 diabetes till delivery, and they have found it to be safe. So now the most of the clouds related to metformin use are now clearing up, and now people say that it can be used. As far as Government of India guidelines are concerned, they said after 20 weeks, but they need to be updated. It's only 2018 guidelines, so we still have 7 years gone. But even DIPSI now, new paper has come, DIPSI guideline. Then we say that after 12 weeks, we can certainly use metformin in gestational diabetes. Those who are PCOs, we should it is being continued for 12 weeks. Global recommendation says that PCO women who are already on metformin, it should be withdrawn after 12 weeks of pregnancy because there is no additional role of continuing metformin neither on prevention of GDM nor on prevention of preeclampsia, which was thought earlier. This is the meta-analysis of PCO cohort is concerned. Our take on this is metformin can be used in PCOS in the first trimester up to 12 weeks. And there are two school of thought. One says it should be continued, one says it need not be continued. There is no harm because the UK PDS has the European NICE guidelines as well as the European guideline now say metformin is safe. So, but GDM, when it comes to GDM, first trimester still no one has agreed to to start metformin as a first line of therapy. Insulin remains the drug of choice. Of course, the second trimester, third trimester, we can certainly use it safely. But most important, before we conclude this particular topic, is the contraindication for metformin. If someone has past history of missed abortion, IUGR, preeclampsia, placental insufficiencies,
Insufficiency.
hypertension, vasculopathy, such patient metformin is contraindicated and it should not be given. A drug of choice is insulin. And when it comes to insulin, always say insulin, insulin, and insulin because it does not cross the placenta. Metformin, glibenclamide, all the other drugs, they cross the placenta. And to the extent of even 70 to 80% of the maternal level. And these maternal, the transfer of the metformin to the fetal circulation might have theoretically some impact on the baby. If not in the short term, there's data coming from the long-term studies of even the data coming from MIC trial, that MIC tofu trial. MIC tofu trial is a drug, a group of GDM1, pure GDM. Nowadays, we started talking about pure GDM, and I appreciate Purvi has also picked up that word pure. So pure GDM. So pure GDM is like GDM, true GDM or whatever. So this GDM women have been given metformin in one particular group and insulin in the other particular group, exclusively metformin, and exclusively insulin. And in the follow-up, they have found that metformin is not a very strong glucose-lowering therapy in GDM because almost 50% of these women required additional insulin therapy to achieve their targets of 90 and 120. So one message is metformin is safe, but it's not very strong glucose-lowering therapy. We start with 500 milligram maybe once a day or twice a day, usually twice a day. And then we go up to 2 gram per day, sometimes even 2.5 gram per day is allowed. It is tolerated, especially obese type 2 women or obese GDM women. It might work very well because it is an insulin sensitizer. And it is about the these women who are put on, and this MIC tofu trial, the extension data. MIG-TOFU trial is basically a follow-up studies of these children born to these women who had metformin versus who had insulin, and now they have a 11-year and 13-year follow-up also. So now this recent data of 11 and 13-year follow-up of these children says the women who were exposed to metformin have more visceral obesity, and this visceral obesity and high fat content in these children might be responsible for increased cardiovascular risk in their adult life. This is again a hypothesis. But when it comes to neonatal outcome, most of the studies, they say the only risk which has been shown in even the MITI trial of type 2 diabetes and MIG trial of metformin insulin, that the small for gestational age baby risk increases in metformin group versus the insulin group. That's the only inhibition of using metformin. That's why you have to be very choosy of starting metformin. It has to be highly individualized. Someone who's clean case, primary, obesity, no bed of static history, no vasculopathy, no hypertension, give metformin. Mild hyperglycemia, 160, 170, give metformin, do wonderfully well. Someone who's non-obese, BMI of 18, 19, 20, early detection of diabetes, avoid early detection of hypertension pregnancy in the first trimester, second trimester, avoid it. So such cases has to be individualized and
So
judicious use.
very elaborated answer and almost everything covered regarding metformin. And just I would like to move very forward to Dr. Dina. What is scenario in Nepal and overall Southeast Asia? What is your thought on metformin?
I mean, because PCOS patients are taking metformin till they are allowed to take it till 12 weeks. So we don't see a reason why a gestational GDM patient cannot be started on metformin in the first trimester. So that's one school of thought and debate. And the other thing that I just wanted to highlight is that I didn't meet Dr. Purvi there, but Dr. Manoj was there for that last year's ADA when they were having this paper out and this study out. And they said that for gestational diabetes, metformin is very good and that's the drug of choice. But the argument was that if they are the DIP patients, so diabetes in pregnancy, they did not want metformin because of the renal outcomes in the fetus. So that was one study that was discussed over there, and I mean it's one of them. But from then, that is why nowadays, if the patient is already on insulin, a lot of times I actually don't give metformin in the diabetes in pregnancy. I just use pure insulin. So for pure GDM, it's metformin, and for pure diabetes in pregnancy, we use insulin.
Next,
So,
Dr. Priyanka,
yes.
you may go ahead. Yeah.
So,
Please, quickly,
yes,
we can wrap up now.
So just, one minor point and one request that I have for our entire, community of obstetricians. I think it will be very helpful to all of us physicians if you can endorse insulin therapy during pregnancy, and allow us that little liberty to use it in appropriate cases, because everybody loves metformin and it's much easier and patient acceptability is also great. But I think there is such an important place for insulin. We need your support and endorsement for that, because you are the primary person for the pregnant woman during pregnancy, and they will only listen to you first and foremost, affirmatively, and then accept anything else that we will tell them.
Very well
yes,
informed.
very well said. Like
Yeah.
the
On
key
the
point over here.
contrary, I'll put a word here. Insulin acceptance amongst type 2 diabetes versus pregnant women diabetes is much more higher
Definitely.
versus anyone else. For the baby, they will do anything, and insulin remains a golden treatment. It's a drug of choice. It's the best drug in the world for pregnant women. There's
Absolutely.
no
Cannot
doubt on.
agree more with you, sir.
Yeah, it has to be the first drug of choice, and everyone should have certainly first choice should be given to insulin. But if a simple case, as Dina was saying, as I also quoted earlier, obese women coming to a clean case, of course the metformin can certainly be safely given now. Of course, we have a plus and minus point of it, but
So,
MITI trial Dina actually has come out with very strong data, except little increase in the small for SGA. Rest all the things were very quite appropriate.
so
So these
quickly,
are the
I
points.
want Dr. Uday Thanawala to have his opinion on insulin and how
Uday
So
Thanawala,
he
hey,
prescribe
hey,
or
Uday Thana is one of the person who promotes insulin. He's a person
yeah.
who
So this
accepts
is what
insulin.
no, no.
actually this is what I want from him
So
for
He
his
knows what he's
community.
doing.
Yeah.
Ritul, in practice, it's a very, very clear indication. If your initial GTT reading is more than 200, just start insulin. If she's in the first trimester, think of starting insulin because you want that glucose level to be controlled very fast, So then there's no time. Insulin brings it down very fast. If you have started metformin in a case, and I would normally start metformin in any woman, a regular pregnant woman, I would have definitely start metformin. Now, but if after that her sugar is not coming under control, she's not getting that 90 to 120 range after means 120 after lunch or dinner, then definitely she goes on to insulin. Definitely she goes on to insulin. And a very important indication for us obstetrician is even if she's showing us proper sugar values, if on sonography I find a baby which is growing too much, or the abdominal circumference is very high, or the liquor is too much, then I know something is wrong. It's not working. So I need to start insulin in all those cases. So insulin is something which we definitely rely on, and insulin is a drug which we have to take so many times. If your sugar is not under control with diet, exercise, and metformin, you have to resort to insulin because you have to prevent that hypoglycemic load going to the fetus.
Great, great. So this is wonderful
And we
message
always turn
from
to
a
the yeah, we always turn to the
obstetrician.
endocrinologist for that in
Thank
Bombay.
you.
Yeah, that's what I was
Thank you.
telling.
Thank
In
you, sir.
Nepal, it's quite easy. Like the gynae screen, and they send it to us. Like we have
Yes,
Okay.
we just
So
we just send it to the
they don't
endocrinologist
treat.
here.
Yeah.
no, they don't start
Right.
even metformin. Like they will just send it to us.
Okay. That's great.
We do that.
As Dr.
So
Sunil said, very important point that any women, me being also mother, they can do anything for their baby. So it is now the part of counseling how you do. You can take any patient on insulin, which I also do, but it is just like you have to counsel them more, and they can come easily on insulin. I would say.
wonderful. Great. Great.
Yes, true.
So we'll move forward to the last question, and we have just 3 to 4 minutes, and we'll quickly wrap up. Then we the last part of monitoring. So how frequently we should ask our patient to monitor by self-monitoring or glucose meter or CGMs. So the technology, how frequently we should use continuous glucose monitoring in our GDM patient or pre-existing diabetic patients.
So I feel everyone knows. I'll be very brief. Fasting, post breakfast, post lunch, post dinner, all post meal blood glucose. If it is a pure GDM, it's going to present to you with normal fasting and post prandial hyperglycemia, and that is why you should be screening. You should be checking their post breakfast, post lunch, post dinner 2 hour. And Dina says some of them they are following 1 hour for less than 140, 2 hour for less than 120. They can follow as per their own recommendation, regional recommendation. That's one point. If the fasting is normal, then you can monitor fasting maybe once in a week. But if it is high and requiring long-acting insulin and some other drugs, then you should certainly monitoring more often. Those are only on diet therapy, maybe monitoring once in 4 or 5 days, twice in a week, and just keep a track of it because as the pregnancy advances, the blood glucose will go up, and that is why there's likely chances that the first one month or first 4 or 6 weeks they may not require anything, no pharmacotherapy, just diet therapy, but maybe as they enter into the third trimester and maybe the 30 weeks plus, they might need some therapy to achieve that particular goal. So monitoring plays an important role, and that's the only tool in pregnancy which will guide you. Now, whether you do it with SMBG or whether you do CGM, because Rutul is a CGM man, and that's why
No,
I
no.
want to take up that question with,
I do
with
use
Rutul.
that.
Yeah, so he will answer that particular question in selected cases. But SMBG, so every pregnant woman once in being diagnosed to have GDM or pre-gestational diabetes or DIP category should have a glucometer at home, should monitor, should be taught for home blood glucose monitoring. They should prepare a chart and should come with the chart, and accordingly the doses of therapy, whether it's insulin or metformin, should be adjusted. That's what is the take.
So, Purvi ma'am, you use more and more CGM in your GDM patients. So this is why I want to ask you a question about CGM.
Yes, I am a proponent of CGM during pregnancy also, but of course it depends on the. I will never ever say don't monitor with the finger stick monitoring. So that's most important SMBG. But again, CGM enhances, used it complements the information that we are getting from SMBG. Uh, yes, there is no recommendation, formal recommendation or added benefit that we see in type 2 diabetes, getting pregnant, or even gestational diabetes, but we have seen how well it informs not only the physician but also the patient in terms of the food items consumed and the impact on the sugars, etc., etc. So yes, I do recommend that, and I do use it in cases where the fluctuations are too many, or there is a doubt that the woman is going into hypoglycemia in the middle of the night, which is very often the case in pregnant women. So
Especially those who are
CGM,
type 1, type 2. Yes, Purvi, I fully agree. Type 1, type 2, dip category, they need more frequent monitoring. CGM might help them in achieving good
yes,
In a
yes.
better way, right?
yeah.
Yeah, I think
Yes.
another
Type
indication
1
would
is
be the
approved.
Yes, sir.
another indication would be the obstetric indication if you would a diabetic, severely diabetic on insulin, and she's at previous stillbirths. I think at that time the continuous glucose monitoring will be very important because we don't want those fluctuations causing another stillbirth.
Exactly.
But always
Yes.
along with SMBG
Yes.
intermittently.
I
Yes.
think that nowadays what we are saying is we call it TIR, time in range. So I think what we want is like in our GDM and DIB patients that it's 90 to 95%, whereas in our type 2 diabetics, I think you want it around
More
70,
than 70.
right? And
70%.
also
Yes.
because the HB1C is
Right.
not viable in these patients because of
Yeah, and the range is between 63 to 140.
isn't it?
And
So yeah,
importantly, prevention of hypoglycemia.
yeah. So TI like time it has to, hypo and hyper both.
VR has to be less.
Right.
I think the hypo has to be less than 3%, right?
That's right. In
True,
type 1,
true,
yes.
true.
But
So
The
with
unfortunately,
this,
guidelines say the
We
range
don't
is
have
what
CGMS in Nepal, so we are
but
just
these unfortunately
manipulating.
this CGM does not have a cutoff of 63 to 140. The
sir, for
TIR
Libre,
is
sir, for Libre now we can do
Yeah.
it up to
Adjust it.
63. Yeah, Libre Pro did not have that facility of going below 70.
We just changed the setting in
it's
the.
actually a recent model or some
No, sir, Libre 1, even that Libre sensor has this facility. Libre Pro
okay,
did not have. Yeah,
did not have yet.
yeah, yeah.
We
So I
changed the
guess,
setting in the AGP to get us the correct.
right,
Uh,
right.
yeah.
So I guess we can wrap up. I asked Dr. Priyanka Kukrele to conclude the session and
So it was a wonderful session with all our panelists and Dr. Rutul, and I thank everyone for being part of today's session, which is one of the important topic, one of the most important topic I would say in diabetes, that is diabetes in pregnancy, and its Southeast Asia perspective. And thank you everyone for sparing your time, and have a nice day.
And congratulations
great.
to Dr.
Thank you.
Bansi Sabu and Rutul for taking up this particular topic on this platform and getting connected to all the IDF Southeast Asia countries.
So
Thank you very
follow
much.
the page of IDF Southeast Asia as well as D Genius, and you can get this video and you can use it on your social media platform. So thank you very much, everyone,
Thank you.
again for joining, especially Dr. Deena Shrestha, Dr. Uday Thanawala, because all other our panelists are commonly seen on our platforms, and we are meeting every week or every month almost. So thank you very much, everyone, again,
Thank you.
and see
Thank you.
you for the next
Thank
episode.
you for the opportunity and congratulations on such a
Thank you.
fabulous
Thank you.
program.
Thank you, man. Thank you.
Thank you very much.
Goodbye. Goodbye.